Welcome all of you to this live program with Orthopedic Principles. Today, our guest of honor is Dr. Michael Uglow from Abu Dhabi, United Arab Emirates. Dr. Uglow is an orthopedic surgeon specializing in management of limb reconstruction and children's orthopedic disorders. Dr. Uglow is the head of the Pele Middle East Clinic in Abu Dhabi. He qualified as a doctor in 1989 from St. George Hospital Medical School in London and embarked on his medical career in the United Kingdom. He was trained in orthopedics in both the United Kingdom and Australia. He was first appointed as consultant in 2000 at Portsmouth Hospital in the UK, and then in 2002 he moved to the University Hospital in Southampton, where he held the role of lead clinician for children's orthopedic surgery, as well as chair of the medical advisory committee of Spire Hospital in Southampton. In 2017, he relocated to Abu Dhabi to work at the Sheikh Khalifa Medical City, where he was the head of the Department of Orthopedics. Since Jan 2023, he has been the head of the Pele Middle East Clinic in Abu Dhabi. So today is my great honor to introduce you to Dr. Michael Uglow from Abu Dhabi. Over to you, Mike.
Hitesh, thank you very much for those very kind words and for the introduction of the invitation for me to speak tonight on osteogenesis imperfecta, a topic which I've had a great interest in and developed a large practice, particularly here in the Middle East, but from my former time back in the UK.
You can use the cursor on the left-hand bottom on your screen. Yeah.
So everyone will be familiar, I'm sure, with the condition of osteogenesis imperfecta. It affects 1 in 20 to 1 in 30,000 people, and characterized by the well-known features of bone fragility with long bone fractures, skeletal deformity, the blue sclerae in some but not all cases, and hearing loss is one of the lesser known features, and fragile teeth, the so-called dentinogenesis imperfecta. It's worth sharing some time just to consider the pathology behind osteogenesis. We know that type 1 collagen affects 90% of the total body collagen, and most of that in bone. It is made of a triple helix, and it's made up of those 3 chains. 2 are of procollagen alpha 1 and 1 chain of procollagen alpha 2. They're coded for by those specific genes COL1A1 and COL1A2. And it's abnormalities in those genes that causes the condition and the variation that we see in osteogenesis. I'm sure you'll be familiar with the Silence classification from 1979. His original 4 groups with 1 and 4 subdivided into A and B based on the presence or absence of dentinogenesis. Now, this is part of the understanding of the increased knowledge we now have of the makeup of the different groups of osteogenesis. Type 1, the commonest, has a stop codon on the long arm of chromosome 17, which blocks the production of the alpha-1 polypeptide. Now, this reduces, therefore, the amount of procollagen by about 50%. So this gives a quantitative reduction in the normal volumes of procollagen. So the quality of it is, the nature is normal, but there's half as much as there should be, making it weaker. In types 2, 3, and 4, it blocks the production of either alpha-1 or alpha-2 polypeptide chains, leading to poorer cross-linkages. And this leads to a qualitative reduction. So we have the so-called mutant procollagen. So there's less of it, and it's of poorer quality. And these conditions generally are more severe. The classification now has to consider the fact that there have been 21 identified genetic types. So it's no longer practical just simply to have 4 groups. The commonest, 1 to 4, with 6 and 11, involve the chromosomes 7 and 17, and these are the most common genes affected. Heterogeneity, however, is very common between, so there's variation within even family groups that have osteogenesis. So from Silence's classification in 79, a little later, Shapiro, also 4 groups with the congenital conditions that are present at birth, and the tarda, those conditions that develop later. And they're further subdivided into the two groups based on bone morphology for the congenitor and whether the fractures occur before or after walking for the target group. Now, in terms of managing osteogenesis, the three main components that we have to consider are the medical management with bisphosphonates, which has revolutionized this condition, deformity correction and stabilization, and weight bearing. These three things are absolutely key. We need to prevent fracture and maintain function. And these are the principles that we will discuss. I've developed this mnemonic: stand. We need straight bones. So if we have bent bones, we need to straighten them. Therapy, physical therapy is essential for the outcome of this condition. Adjunctive medicines, this is the use of bisphosphonates. Nails and plates, this is how we're going to fix and stabilize the deformity correction. And D for vitamin D. So bone health is classic. So stand is a useful trigger to consider those main options in the treatment. So bisphosphonates, zoledronic acid has become the favored type because of its mode of delivery and the frequency. Permidronate used to have to be given much more frequently than bisphosphonates. Generally, for corrective surgery, 2 weeks prior and 3 months following will give the best effect. The dose varies depending on age and weight, and this is something that for routine management will then should be given every 6 months in order to maintain optimum bone health. We know from earlier work that if bisphosphonates are given too frequently, you have areas of bone that in fact become harder and almost osteopetrotic, and this causes fractures as well as the osteoporotic bone. So getting the balance right is important. So pre-testing for people, the patients undergoing zoledronic acid, it's important to do have a collaboration with your physician colleagues, particularly endocrine specialists who develop these protocols. Complete metabolic panel with calcium, phosphate, and magnesium are the most important. Vitamin D is, of course, vital, and these dose variations are what are important in order to, depending on age, to optimize. These are the maximum doses that can be safely given at the 3 different age ranges that you see on the left-hand side of the slide. In terms of vitamin D replacement, as ergocalciferol will allow us to give much higher doses where we need to play catch-up as opposed to cholecalciferol, but both are viable options to use. So 2 weeks prior to the infusion, then calcium supplements with vitamin D supplements, if high-dose therapy is not being used, will be started. Hydration is very important during the administration of zoledronic acid. Acetaminophen or paracetamol, depending which part of the world you're in, will be given because you may have pyrexia and bone pain with the infusion. Baseline calcium and vitamin D levels are taken on the day. So the first dose, as I say, is 2 weeks prior, and second dose 3 months after surgery. It's given with normal saline, and these different doses are varied depending on the weight of and the age of your patient. Now, in terms of concepts of weight bearing, we're all very familiar with Wolff's law, and I think the Frost's Utah paradigm is a very useful way of understanding what is important in weight bearing and function in relation to our bone health. And we can see that the work by Frost has shown that bone gain, the area in green on this graphic, occurs where there is considered overload. So disuse will give bone loss. The adapted state is maintaining bone density and bone production, but it's overload that increases the bone mass. And this is important because it means we have to focus on active function where patients are standing, weight bearing, walking, and undergoing therapy in order to increase their bone density and their bone mass. So what about deformity correction and stabilization? This is a typical presentation of a young child who's almost 2 years of age. Characteristic deformity from multiple fractures. You can see in the left subtrochanteric region is the most recent fracture, where there's still the maturing callus. How do we get a patient like this to weight bear and to prevent this disease of recurring cycle and the downward spiral of fractures? Fractures and cast care lead to immobility, which lead to worsening bone density, which lead to more fractures. And that is the cycle that we have to break. Historically, and nailing has been around for many years. And when you research these topics, it's always longer than you may think. But the initial idea of straightening the bone and putting a straight rod was entirely reasonable. But of course, we had problems of migration, and with growth, the nails cannot catch up. So you would see these situations where stress rises are formed and further fractures could occur. So the evolution to a double nailing technique, you see a rush nail with a long K-wire as an option, which gives a telescoping option through growth, which is the earliest way of coping with a telescopic system. And then this matured through Bailey-Dubois into the Sheffield rods, and now subsequently the most commonly used will be a Fassier-Duval. So for this patient that I've shown you, this is the sort of approach in order to try and get this child up and walking. And this is a lot of surgery, and this is an aggressive approach, but it means you can get the patients up and moving and maintain their bone, get the bone health to a much better state. It's challenging. So you can have perioperative fractures. We had a split of this proximal fragment. It needed 2 osteotomies, the Sofield principles of the so-called kebab procedure. And in the tibia, you can see that we've used a wire to hold through the new generation of these nails to hold in place to hopefully stay in the right part of the bone in the epiphysis, and then to telescope properly during growth. So the aims of treatment are to correct the deformity, to use a telescopic intramedullary nail, tethered to the epiphysis, and to control rotation. So the weakness of Fassier-Duval particularly is that they have very poor rotational control. So something additional. In this child, when they're young as this, you can see that we have to use a cast. So we use a cast for as short a period as possible till we start to see some callus, and then controlled weight bearing with the physical therapist as early as possible in order to start stimulating the bone with production to try and increase that bone density. Just a technical note, the position on the operating table with a bump under the pelvis, the leg can be flexed and adducted to give good access to the trochanter, and you can get AP and lateral x-rays without moving your x-ray machine, which is much more convenient. And this child, a year and a bit later, it's now 3 years, and you can see that the bones are growing. You can see the characteristic lines from the zoledronic acid infusions, and those fractures where we had the deformity up in the proximal femur has healed and developed very nicely. If we look closely at the distal tibia, so this wire in the left tibia clearly was not in the epiphysis. It is, however, having a function. So if we compare to the other side, where there was no wire, it was not possible to get a wire in on this side, then this one has migrated and is not telescoping in the same way as on the left side. So in the very young kids, I would urge that it would still be relevant and important to try and tether this nail to maximize the effective telescoping that we possibly can. You can see the difference in length as they progress, and this is something that would just buy time until you have to revise. Let's take an older child now that's already had correction, and you can see for the astute that the left side, the nails are thicker, and we've got much less of the male component showing. And on the right side, the thinner nails with a longer part where there's been telescoping, clearly because the left side has been revised. So this one was in fact revised because of a fracture in the femur. When do you revise the fasciae duval nails. There's no definitive answer. However, you have to make a judgment of whether the bone is staying straight, whether the bone is deforming, whether the nail is telescoping, and how much nail will be exposed before it then is less effective than having another female, much thicker nail further down the femur. Now, if we look at the tibia, we thought, okay, well, maybe we should wait a little. And oops, this child was out on a scooter trying to be very active and caused this rather unpleasant fracture. Now, if you get a bend in the nail like this, that's obviously extremely challenging, and you're going to have to go to surgery, and this nail has to be cut in situ in order to retrieve both sections of the nail. In order to do that, you have to increase the deformation, and then you can retrieve with the retrieval tool in a much easier way. In terms of placement of the wire for the revision, using the reamers to guide the wire is a useful tip. Sometimes the wire can be difficult to pass exactly where you want it, and giving stability, passing the reamer so far and then advancing the wire can give you a very effective way of getting into the center of the epiphysis. You want to seat this as central as you can, distally in that epiphysis, and depending on the age and the quality of the bone, you would choose whether or not you're going to rely just on these screw threads or whether you're going to go for the additional hole fixation. And a little tip about that, if you over drill, so if you're going to put a 1.6 millimeter wire or 2 millimeter, depending on the size of the nail, then take a drill and drill the cortex on the, whichever your axis side is, typically the medial, although it's easier to bury on the lateral, but you'll go in medially. And if you make a larger drill hole, then it's much easier to get the wire into such a small hole. As far as rotational control, now we have generations of low profile plates, and the addition of a plate around the nail will give you that rotational control that we don't get without it, and it avoids using a cast. So in this patient, we can get her into clinic, and this is her walking at 2 weeks. So 2 weeks post-op, and she's already walking unsupported. She will use a frame for some support during therapy, but she can walk short distances at home. And this is, I think, a very good example of aggressive surgery, controlling the rotation, good stable fixation with as big a nail as you can get, and then early rehabilitation. And this will hopefully prevent the refractures. This is the same patient. Now, the femur shows that the nail has migrated proximally here. We've got also problems at the lower end. So if we look closely, there's the migration, the nail is sunk. If we look distally, the nail is bending. Not only the nail, but the bone is also bent. And in fact, that nail is no longer, assuming it was, and I'm pretty sure it was, but it's no longer intramedullary. This is at best intracortical, and at places will be extra cortical. And this is quite a challenging situation. So we know the fasciae duval, they are very useful, but they are not perfect, as nothing is, but there are a number of complications, and you need to actively look for them and manage them. So we see loss of proximal or distal fixation, as we've seen. We can see migration of the nails. Implants can break. They can fail to telescope. The intra-articular, there's a risk of penetration in conditions where there is progressing deformity. We can see refractures, and we can see bending of the rods. Now, how does all these things help us with learning when we have to revise? So the fate of the bent rod in children with OI is a recent publication which has looked at this question in detail. And overall, 27.4% of the rods that they looked at bent during the follow-up period with an average angulation of 7 degrees, 7.3 degrees, with a range of 1 to 24 degrees. This is a large study with 168 telescopic rods. And in severe OI, 15.7% rods bent, and in non-severe OI, 35.7%. So this will imply, one assumes, in terms of relation to activity. And if we look at the independent ambulators, 34% of those have bent rods, whereas 20% of the non-independent ambulators had bent rods. So clearly, mobilizing and weight bearing is producing deforming forces. We want the bone to increase, but we've got to have sufficient strength in the supporting nail and or plate to try and prevent deformation. So the time to revision of the 34 bent rods that were not revised early, the time to revision or final follow-up was nearly 30 months. And of those, 25 or 73.5% continued to telescope, and 14 or 41% increased the angulation by an average of only 3.2 degrees. And 30%, however, did refracture. So it's not an absolute that you necessarily have to revise immediately, and you can choose that to just follow these patients. If we look at this 11-year-old girl, she has a very severe form of osteogenesis, and these rods have been left a long time before revision. And she's spending a lot of time in a wheelchair. You can see the quality of the bone is poor. We can see extracortical bone here on the shaft. And this is a situation that needs to be observed very, very carefully. You can see that there is, in fact, now an impending fracture right at this end of the female component of the nail. One example of the proximal wire hole being used to hold it in the epiphysis in a very weak bone situation. This is the tibia, and again, you can see how these wires are holding the bone in a very good position to give the maximum chance, but it would appear that there is some form of growth abnormality with progressive varus deformity. So certainly not without its potential complications. So at 12 years, 9 months, you can see here, this is fractured and healed, and this is a great risk of further fracture and will need revising in order to try and get this patient mobilized. And this is the situation with the tibia. At the moment it's holding, but we've pulled out distally on the right side, and you can see how the deformation is progressing, and this is then at risk of perforation through the anterior cortex. This patient, a 10-year-old boy with type 1 OI, presented first with this mid-shaft fracture and a bent rush nail. He had treatment in the Philippines originally, and this is the double nail technique that I showed you before, which has been holding his right femur, very well indeed. His tibias are also holding up, but you can see with growth how we've got this exposed bone and progressive deformation, which is likely to cause him problems. He's now was spending a lot of time in a wheelchair and is keen to get going. So the left femur corrected that femoral fracture, had to remove the broken nail and insert a fasciae duval. Again, problems with the proximal section. So consideration of additional supplemental wire either side of the nail, bent down onto the shaft with cerclage wires is a classic technique and very useful to protect the femoral neck, which is also not usually protected with the routine fasciae duval, as we see here. Over time, 10 weeks later, everything's healing fairly satisfactorily, and we did the left tibia at the same time, and he's now beginning to get going with therapy. but his right side is the one that holds him back. You can see the progressive procavatum deformity, and so he's had revisions on the right leg. So it's a good plan to operate on one leg at a time if possible, and this will reduce the number of total surgeries for these patients. Revision nailing is challenging and humbling, as I was reminded only this very week. In order to get a nail out, so a guide wire to a sunken nail at the top using an ACL reamer is a good trick to expose the bone. The tool to try and retrieve that nail is not always able to give a good grip in the top of the female component, and that can give quite a problem. And when you can't retrieve it, you have to approach the bone through the apex where you're going to do your osteotomy and retrieve the nail at this point. So here you, with care, cut around the nail. When you access the femur, this right-hand picture is showing a laminar spreader. So we separate or take a section out if you need to, identify the nail. And here on this left-hand image, you can see that we're using a burr to cut the nail in situ. No one likes doing that, but you have no choice. You have to get this nail out. So this will then allow you to push back and retrieve proximally. And then on the distal section, then you can retrieve using the tool. This was a bent nail and didn't want to come out and took some considerable time, but keep working through the steps and eventually you'll grab hold of it and be able to get it out. Once you have got it out, then making a new channel down the center of the bone is very important. This patient had an extracortical nail, and of course the guide wire would very easily pass through the same track. So using an anterograde retrograde technique and reaming from both directions creates a canal that you control for your new nail. So this is our 10-year-old revised a year later, and he's got straight bones, the nails are telescoping, and he is now well placed to be continuing with his zoledronic acid and his ongoing therapy. Now, what about the femoral neck? I've mentioned it a couple of times. It is a risk area with the nails that we use. This patient was treated with a plate and which cut out, and there was progressive deformation, and presented to me with this coxivera and loose metalwork pressing up against the skin. So I chose to revise this with a blade plate. This gives a wide surface area compared to the narrower purchase of a screw. Once this is healed, of course, there are potential problems with this, and this is going to need careful follow-up and revision because the end of the plate will be a stress riser, and this will need removing, nailing, and then with or without the wire protection for the neck that I mentioned previously. So this is now healed, the patient's up and mobilized, and then we can get that to mature and then look to revise. This patient had a much more severe problem, having had a fascia duval nail. There was no, there was progression and pain, and she's reduced weight bearing, and she was deforming her femoral neck, which then did fracture. And you can see this tomogram, which basically has confirmed that fracture. And this is a situation that is going to need careful revision. Now, over time, this fracture did actually heal. And when she got to us, it was united, but this is at risk. Obviously, in terms of walking, her abductor lever arm is much shorter, and she's got a very poor stance and gait, very weak. And this is something that needed reconstructing. So in order to correct the anatomy of the proximal femur, I did the osteotomy and used a plate, and I wanted very much to have an intramedullary protection as well. And this is a 2mm wire, and that's the only thickness I could get past the screws. So placing screws in such a way is an advantage, but with these fixed locking plates, as opposed to vari-angle plates, that's hard. So a variable angle system would be preferable, so you can have more of a channel in which to pass an intermedullary wire or nail. And the agreement was that we would revise this for a nail. The child is now skeletally mature, and she did develop a stress fracture. The father was very unkeen for further surgery, and we are now at this situation where it's healed. She is able to stand. She's in varus, and I'm sure that she's at risk of fracture if we don't resolve this. If you look at the right side, she really does have a very narrow shaft, and there's not a great thickness is going to go through this femur. So sometimes it is a very great challenge to follow the principles that we're advocating. So the foot is another area in osteogenesis that fairly typically is planar valgus and can cause problems with weight bearing, and this is something that can be difficult for these children. You can see this case, really is an oblique talus, so very marked obliquity, a very tight Achilles tendon, valgus hindfoot, and flat piece planus. So this is a situation that's going to need managing. It's definitely a good idea to splint these children either with an SMO or an AFO. And this paper from the Clinical Orthopedic Surgery in 2020 shows that they were advocating using a patella tendon supporting AFO, which gives maximum distribution, which is definitely an option and still allows the patient to be weight bearing. Now, the spine in osteogenesis, that's another talk. I'm not a spine surgeon, but clearly vertebraplanar are things that we see with the classic kyphosis and kyphoscoliosis. And I'm sure that Hitesh will have an expert speaker lined up in the wings to discuss the spine in OI another day. So in summary, I advocate the STAND principle for treating patients with osteogenesis imperfecta. We want to give them straight bones. We want them to have therapy and for them to be up and walking. We need adjunctive medicines, particularly zoledronic acid. Nails and plates will be the mainstay in how you use them. You can learn some tricks in order to maximize the mechanical advantages, and vitamin D, ensuring that the bone health is optimal. So in terms of fixation, I think as large a nail as possible, but without removing bone. We obviously have to ream to get a straight bone, but I'd rather do another osteotomy than ream out more of the bone itself. So that balance is important. Ensure competent fixation both proximally and distally. You need an additional anti-rotation hold plate if there's room around the nail, but if not, a cast, and for as least time as possible, but still weight bear in the cast. Our osteotomies will end up being horizontal, the transverse, so weight bearing causes compression, so we should not fear weight bearing on them. Follow-up is very important with serial x-rays, looking for bending, looking for the risk of fracture, making sure the nails are telescoping, and monitoring that situation and discussing with the families when we think the optimum time to revise. I think it's better to control the fracture as a surgeon by doing an osteotomy than to let the child fracture uncontrolled. Revise if these problems are progressive. So keep an eye on bone health, partner up with a endocrine specialist, somebody who has an interest and expertise in metabolic medicine. Keep an eye on their vitamin D. It's very easy to replace. Make sure they're having 6 monthly bisphosphonates and encourage walking and activity as much as is possible. So STAND is what I shall leave you with. Thank you very much indeed for your attention. Thank you, Hitesh, for the very kind invitation for me to talk, give this presentation this evening. Thank you.
Thank you, Mike, for this fantastic presentation. Mike, you can stop sharing. Thank you, Mike, for this fantastic presentation. You have covered the entire spectrum of osteogenesis and, of course, the orthopedic issues, which are our daily bread and butter.
Thank you.
Mike, a few questions.
Sure.
Mike, you mentioned about zoledronic acid in the medical management, right? So there are some reports like, for example, the denosumab and teriparatide usage. So do you have any experience? Surgeons have started using those?
So I have not started using those. So I'm aware that that is the developing area of research. And as yet, I think the protocols are not clearly defined. And that work is definitely interesting and definitely something that will have a place. I chose to stick to what is known currently without going into that, and obviously without wanting to take too much time. But definitely that is one to watch because that will develop for sure over the coming years. I'm very sure of that.
Thank you, Mike. And Mike, when is the first time to nail? For example, you've made a diagnosis first. Say the kid is very young and you've made a diagnosis and there was a first fracture. So when is the first nail going in? Great
question. So in an ideal, so the ideal theory for me would be just before they bear weight. Now, I think in reality, you have to be able to get the smallest fasciae duval nail in situ, which is a 3.2 millimeter nail. So measuring the medulla is wise. We now, of course, have a generation of slim nails. Now, that is an option. So just like the old, just the principle of putting a rush nail, but the slim nail, for those who aren't familiar, is a solid nail, but it has the threaded top, just like the female component of the fasciae duval. So they migrate much less than the original rush nail. So that is an option to place a thin, slim nail into the bone and explaining to the parents that the child will grow, it will deform and need revising, but it buys time. So that is something we're definitely starting to do in a very young child. But in ideal world, Hitesh, is when the child's weight bearing and they have deformity in OI, they're clearly at risk of fracturing. So it's trying to prevent that fracture.
Thank you, Mike, for that. And Mike, we have evolved with these nails. For example, we started with the Soffied Miller osteotomy, went to the Sheffield system, the Bailey-Dubois, and now the fascia duval, right? But the principles remain the same, right? It's with the same Soffied Miller, right? If you have a deformity, make multiple segments and then nail, isn't it?
Exactly right. So as many osteotomies as you need. So I think I mentioned that that's the sort of conclusion. We know from trauma nailing and stature lengthening that if you, in order to get a straight nail in a bent bone, you ream more. And I think in osteogenesis, I would not advocate reaming more to avoid doing another osteotomy. I would do another osteotomy to avoid reaming more. I think that would be definite switch in principle there.
And what about the approaches? For example, there are many levels, right? So is it a single incision or you do multiple percutaneous?
I would choose multiple percutaneous. So a lot of I try and do them percutaneously if I can. It's technically more challenging. You may have to open and do a retrograde antegrade technique. So one of the osteotomies may end up being a bigger incision. But I'll start with trying to do them percutaneously, Hitesh, and then proceed from there.
Thank you, Mike. And Mike, how do these nails actually work? For example, I was just looking at data. It says if you're using the fascia duval, you can, suppose it's the femur, you just need one incision on the proximal side, right? And you don't need an incision in the knee. So that is advantage that is for the fascia duval. And does the distal part of the nail tether into the physis or something like that, and the proximal grows? How does it work actually?
Okay, so that's a great question. So the screw thread of the male component is you do not pre-drill the epiphysis. So you center it as close to center as possible. And then as you insert, you are literally screwing home into the epiphysis. So it's bound by, it's a screw fit into the bone of the epiphysis. And you need to be very careful how you do that. So obviously you don't go too far. You don't want to back it out. So make sure that you're following it very closely on X-ray in both planes. And when you take off the introducer, it's very important to put the obturator on every set. There's an obturator that you pass that right down onto the top of the male component, and very, very gently pull the introducer back, checking on image that you don't inadvertently pull your threads out of the epiphysis. We know from many, many studies, the work of Ogden, for example, the original work on ACLs across the proximal tibial physis, that a tract through the central third of the physis will not cause a growth arrest. So it's important, I think, not to be peripherally. And I think if you're in the middle, it's very unusual. I did show you a growth arrest on the proximal tibia. It's very unusual to cause a growth arrest by this technique.
Thank you, Mike. Just one last question before I end up the session, Mike. So suppose someone is diagnosed with an osteogenesis imperfecta, and if it's a moderate variety, so how many reoperations, for example, how many surgeries would this child have by the time he or she grows into an adult?
So I think if you're starting, let's say, approximately age 3, then realistically, 3 revisions through childhood, with a final revision at maturity or close to maturity, to leave them either with the solid lock nail or solid slim nail, to then leave them for their adult life, hopefully without further fracture.
Thank you, Mike. Mike, I think that's all the questions that we have for the session. Thank you for this fantastic presentation, and I'm sure this is going to benefit a lot of people.
Hitesh, thank you again for the invitation. Thank you very much indeed.
Bye-bye.
Bye-bye.